our chairman, Dr. Anjana, Dr. Ranjit, and all of our staff. There was a fantastic talk by a previous speaker, and I'm going to talk on the same lines, patient empowerment in diabetes management. But what I'm going to talk is about how we need to focus on educating rural India. And I'd like to share a couple of success stories by MDRF, Madras Diabetes Research Foundation. Yeah, so before I actually jump into the talk, I would like to throw some statistics here. The latest IDF stats say 537 million adults are living with diabetes, and the projected numbers are 643 million by 2030 and 784 million by 2045. And many people are worried about COVID, but we are losing people are dying 1 every 5 seconds, and there is estimated 316% of increase in expenditure. That's USD $966 billion that has been spent for the health expenditure related to diabetes. And so what's worrying is there are a lot of patients, a lot of people who are underdiagnosed. 41 million adults have IGT. So coming to Southeast Asia, we're looking at 90 million and projected numbers predicted to 152 million. So we need to be doing something about this. These are staggering numbers. The main problem with diabetes is we just talked about the tip of the iceberg, but there are a lot of undiagnosed. There's a lot of work to do. This is the one below the level is what we need to be addressing. So a simple snapshot of what's the numbers in India. We're looking at 1 in 18 adults have diabetes, and more than 57% of people with diabetes are undiagnosed. So what are challenges unique to India? So let's talk about India. So there is an explosive increase in both cases, both in urban and rural areas, limited resources, paucity of physicians, trained medical staff, and we all know about the high predisposition of how diabetes behaves in the thin nation phenotype, and how we are at more risk of developing complication. But I would like to focus on the line here. Understanding how India deals with diabetes mellitus can help other low and middle income countries. So we need strategies, we need models, we need ways to actually tackle diabetes in India. So if you look at the reality, and among all the population, at least more than 70% of India's population live in rural areas. So unfortunately, most of the diabetes efforts are in the urban areas. Thanks to all the work that is being done by RSSDI and different physicians at different parts of India, things are changing. But what you have to understand is we're looking at 34.9 million diabetic individuals just in the rural areas. So initially, people used to think that diabetes is a disease of it is because of urbanization. But I think I will show you some statistics in the upcoming slides that things have changed. There is increasing prevalence in the rural India. So though the prevalence is relatively less compared to the urban, the numbers are more. So if you don't tackle the rural areas, if you don't focus on the rural areas, we can never defeat diabetes. So why we need to focus on rural India? So as I already said, 70% of India's population is living in rural areas. Most of the diabetes efforts are in urban areas. If you look at the ICMR INDIAB study, it shows that the undiagnosed to diagnosed ratio is higher in rural areas. So if the patient are not getting diagnosed, obviously the complications are high. We all know about the bad metabolic memory, and patient obviously and eventually presents in a very late stage needing tertiary care. So there is also a lot of work to be done. There is lack of enough data. We don't have a lot of data in the rural areas. So even in those people who self-report, only 1/3 probably really have good diabetes control. So these are the reasons why we need to be focusing more on the rural India. So I'll just quickly mention the challenges we all have. We all know, and we just want to emphasize on that, of reaching out to rural India. One is inadequate healthcare resources, poor infrastructure, lack of awareness, illiteracy, limited physicians, paramedical staff, limited access to health, problems with transport, and obviously in India we all pay from a pocket, and moreover, especially if you focus in the rural areas, most of them are living in poverty. So what we need an urgent, I would say there's an urgent need to develop healthcare models which can be reproduced and which are actually tailored to rural areas. So I would say there is an urgent need for this 4A test, that is to make diabetes care available, accessible, affordable, and acceptable in rural India. So before I actually talk about the one model, which is, I think most of the august audience would know, I would say more than 70% of qualified consultants, specialists, and experts are practicing in the urban areas, and only few are there in the rural areas. But most of the efforts needs to be done in rural areas. How do you actually connect these two? How do our rural Indian diabetic patients deserve a specialist care? So if we need to think, people who are actually making policies, strategies, we have to come up with innovative ways to bridge this gap. So one such project is Chunampate Rural Diabetes Project. I will tell you a couple of examples. Most of you all would know about this, but I'd like to elaborate a little and comprehensively expand. So Chunampate model for rural diabetes care is a mass awareness screening program for 1 million rural residents. The goal of it is to create mass awareness, detect, and also screen for complications, and then also provide diabetes care. So this has been done in Chunampate. Chunampate is in Kanchipuram district of Tamil Nadu. So the main key here of the model is using technology to bridge this gap between the urban and the rural population. So tele-diabetology to reach the unreached. So the components of this model were, one, the tele-diabetology van. So this is the tele-diabetology van. The facilities were retinal camera, Doppler, biothermometry, ECG, VSAT dish, video conferencing equipment, computers, and laser printers. So we had a van, and we also had trained technicians. What we did here is, the people from the local community who were unemployed, they were recruited, they were trained at our center in Chennai, and then it was actually an employment opportunity for many of them. So this is the basic flow chart. 23,380 numbers were screened, and self-reported were 808, newly detected were 330. So in 23,380, 1,138 were the individuals with diabetes, and those are the complications: retinopathy 18.2%, neuropathy 30.9%, and PVD and CAD. So I'll just want to play a small clip. Can you play the clip, please? Yeah. So these are our trained people, where most of the physicians and even technicians were employed from those Chunampate and surrounding villages, and they were taken consent, and then they were screened. Basic anthropometric measurements were taken. So they were taught how to measure BP, how to use the glucometer, so then whoever had a fasting blood sugar more than 126, they were actually, we did an OGTT, and also complication screening was done in this fully equipped van. So this is the ABI testing and biothermometry, and we did it 7-field color Doppler photograph of the retina, and this was connected through tele-diabetology. The consultant in the Gopalapuram center was actually advising them. And some people who were actually in high risk, people who had hemorrhages, people who have in severe PDR, they were actually referred to this center, and these people were actually given free of cost treatments, and many were given heavily subsidized treatments. So I'll just skip that because of lack of time. So basically, this model actually created employment opportunities for the local people, and we could do mass awareness and also screening, and also most of the people, if you see 1,000 diabetic patients, all of them doesn't need tertiary care. Probably only 20% would need a tertiary care. To pick up those people and then connect to the tertiary care was the using telediabetology was, I think, a very impressive model. So these are the benefits of the telediabetology. One is availability of diabetes care facilities at doorstep, easy accessibility, employment opportunities for local people, and increasing awareness and facilitating remote monitoring and information delivery. So even many foot cases were actually, the pictures were taken and the surgeon was looking at the center, and there was also a local center, Sai Rural Diabetes Care Center. Most of the patients who were not that serious were actually treated there. So we were given footwears to offload the feet. So this was well received, well appreciated, and did get a lot of electronic and print media coverage. So this slide I was just showing, 2006 to 2010 is the Chunampate Rural Diabetes Project, but you see when you look at the increasing prevalence in the 2011 ICMR INDAB study, and the Trend Project, which was a collab between MDRF and the University of Dundee, Scotland, showed an increasing prevalence of 13.5%. So I'm running out of time. So this is the Chunampate Rural Diabetes Project. So though this is not relevant, the next model I'm going to, which I've showed, is not relevant to the rural, but I'd like to emphasize this community intervention and creating awareness in the community is the only way to tackle this diabetes epidemic. So this is called, the second story I want to present here is the Asian colony success story. So basically we took two different groups in Chennai. One is the middle income group, and the other one is the low income group. So what we found was the middle income group had high prevalence of diabetes compared to the low income group. And then what we did, so for the low income group, we gave a standard advice, so standard medication standard. We didn't put a lot of effort there. For the middle income group, where the prevalence was high, we actually created a lot of awareness, a lot of, in the form of brochures, talking to them, counseling them. What happened, and when we followed up after 10 years. So before, what happened after doing this intervention is, most of them were motivated, and with their own funding, most of them collected their own funds and built a beautiful park. So this is the park which you are seeing. So we followed up this middle income group and the low income group after 10 years. What we found was, surprisingly, as you can see here, middle income group in 2001 was 12.4% of prevalence. It only increased to 15.4. So middle income group was where we talked about diabetes, where most of education was given, most of counseling was given. We did follow up. So, but if you look at the low income group, so you can see a 135% increase where we didn't actually did a proper diabetes education. This emphasizes the need for diabetes education. So we're looking at huge numbers. We can't ignore rural India, because most of the efforts, if you ignore rural India, we can never defeat diabetes. We can never control this massive, more dangerous than the COVID epidemic. Many people are talking about the COVID, but actually there are people dying every second. So take home messages, 70% of Indian population live in rural areas, so we shouldn't, there needs to be more, we need more efforts, more data, more education, and telediabetology might be one model that can actually connect these people who are the specialists in the urban people to the people who are living in the low income or very rural areas. So undiagnosed to diagnosed diabetes ratio is higher in rural areas. So very, very important to educate them. The success of Chunampate Rural Diabetes Project lies in harnessing the power of technology. Probably, I think we can't ask every consultant to go and set up there in the rural, but this can be used. Second, the Asian colony success story shows the importance of community empowerment and community participation. I think without involving people, without involving the community people, we can never actually defeat this. The success of Chunampate was that because we employed everyone, even the physician, even the technician, we picked up unemployed youth and we trained them, and then they had a good rapport with them. So we need to do, the job was less. We all only had to do the screening through telediabetology and then pick up and then refer and treat adequately. So thank you everyone for this patient listening. I'm very honored to be here, and once again thanks for the opportunity.